Okay, thank you, Beth, and welcome everybody to the 25th year. This is my 11th year, so I'm excited as everybody else is, and for all the organizers that put this together and inviting me back. So my work today is to talk to you about some updates on aspirin, in particular in the field. There are a lot of updates with aspirin, and I could talk all day about that, but specifically we want to talk about patients in the cath lab and the use of aspirin in an even more specific cohort, those patients with atrial fibrillation. Let's see here. So what is the, just hit play. Click. Got it. Thanks. These are my disclosures, none of which will pertain to the talk today. So the learning objectives are fourfold. We'll look at the scope of the problem, the epidemiology of patients with atrial fibrillation and CAD undergoing PCI. We'll examine the existing approaches for the use of triple therapy after PCI. We'll summarize some of the sentinel trials that support the use of anticoagulation and antiplatelet therapy in atrial fibrillation and PCI. And then very timely, some new guidelines have come out that I think Dr. Sharma touched on in his talk regarding antiplatelet anticoagulation post-PCI patients with atrial fibrillation. So it's always better to always start with an illustrative case. So this is a 72-year-old female who came to us with a history of diabetes and hypertension. She was a prior smoker with underlying lung disease and peripheral arterial disease. She had an ejection fraction of 35%, a normal hemoglobin and renal function. She came in with chest pain and a positive troponin consistent with an acute coronary syndrome. She had new onset at the time of atrial fibrillation, which you see on her EKG in the upper right-hand corner, with a rapid ventricular rate and a CHA2DS2-VASc score, risk score of 6. And the question is, how do we treat this patient? I think it's obvious that we have to take care of something in that LAD, but what do we manage? How do we manage that treatment after? And what are the risks of doing so? So we'll hopefully be able to answer that as we go. Oops. Well, we'll go forward. All right, so just to get a scope of the issue, so between both Europe and the United States, there's approximately 1 billion people. Around 2% of those patients have atrial fibrillation by diagnosis. And around 80% of those patients have an indication to be on oral anticoagulation for primary stroke prevention. It's a very, very high prevalence of patients that need this medication. About 30 to 40% of those patients that have indications for anticoagulation have coronary disease. And about just less than 50% of those patients are going to undergo revascularization, typically with a PCI. So you're looking at about 1 to 2 million patients per year that fall into this category. This is not a small number. So the scope of this problem is enormous. And there's a couple of key concepts when we talk about PCI and atrial fibrillation. We all know that dual antiplatelet therapy, or DAPT, is the choice of medications we use to prevent the dreaded stent thrombosis. That's the diagram on the left. But it's a little bit different. And we know that dual antiplatelet therapy is better than anticoagulation in doing that. But in atrial fibrillation, due to different mechanisms, oral anticoagulation is better at preventing a stroke when you compare it to dual antiplatelet therapy. So a little divergent treatments. The problem is when you get in the center where you have an overlap. And when you have an overlap with those patients with coronary disease, get a PCI and atrial fibrillation, you put them on triple therapy, you are going to increase their risk of a bleed almost 40%. So it's a real problem. And for anybody that's taking care of patients with a fresh PCI with a drug-eluting stent on triple therapy, you understand this talk. So some of the data until recently, probably the past 5-6 years, we've been going on warfarin, or vitamin K antagonists. And it's worthwhile to look at some of the data that supported that. And it's largely one trial This was called the WOEST trials. What is the optimal antiplatelet anticoagulation therapy in patients with coronary stenting? This is about 500 patients were randomized to be treated with warfarin plus a P2Y12 receptor antagonist, clopidogrel, versus warfarin, aspirin, and clopidogrel, so triple therapy. And they looked at our year outcomes, and the primary endpoint was any bleeding. And it's pretty impressive. So what they saw is by eliminating aspirin, by using just the vitamin K antagonist and clopidogrel, you had almost a 55% reduction in bleeding. The blue line is the triple therapy. Aspirin, warfarin, and clopidogrel. Significant amount more bleeding compared to the double therapy. So this was eye-opening for us. I think this changed the way we practice. We started treating all of our patients to get a PCI with a drug-eluting stent after this trial with just using clopidogrel and warfarin. And then what happened in 2010 is the first novel anticoagulant therapy or agent came out. This was Pradaxa. This was a direct thrombin inhibitor. And in doing so, it started replacing warfarin. And you can see the penetrance of these agents over the past 5-10 years has been just exponential. And especially in the pandemic, where the patients could not come in for their INR checks, we converted 200 patients a month over to all DOACs. And it pretty much replaced the vitamin K antagonists. So very rarely do we see these patients. And in doing so, we really found out that this might be a safer medication in patients to undergo PCI. And there are sentinel trials over the past 10 years that have shown this. And I'm going to go through just very briefly what these are. So not only has the medication advanced with the use of DOACs, but our stent technology has advanced. We've gone from very thick metal stents that have a very pro-inflammatory response when they're embedded in the vessel wall, to now ultra-thin stents with almost half the profile and a biodegradable or even polymer-free platform, which significantly reduces that inflammatory process and promotes the healing. So your duration of antiplatelet therapy is becoming less and less. So it's the combination of both of these things and these trials that has really led in or shepherded in the use of the DOACs and P2Y12 receptor antagonists. So probably the sentinel or the most impressive trial, earlier trial, was the Pioneer AF trial. This was around 2,000 patients, compared rivaroxaban plus clopidogrel to a lower dose rivaroxaban plus dual antiplatelet therapy, so triple therapy, versus warfarin and dual antiplatelet therapy. And the bottom line is those patients that received rivaroxaban full dose plus a P2Y12 receptor antagonist such as clopidogrel had significantly less bleeding. Landmark trial. Dabigatran is the other one. This was the ReDual trial, and that compared also around 2,500 patients. Very similar endpoints. Bottom line is when you compared dabigatran plus clopidogrel, you had significantly less bleeding compared to triple therapy with warfarin and aspirin and clopidogrel. There were two doses of dabigatran used. One was 110 milligrams, the other was 150. Of note, the 110 milligrams was actually associated with a trend towards higher myocardial infarction and ischemic endpoints. So that's probably not the dose you want to use when you're going to use combined with clopidogrel. AUGUSTUS is the one that's related to Apixaban. This is randomizing about 4,000 patients to Apixaban plus aspirin and a placebo versus warfarin plus aspirin and placebo, and very similar outcomes. Bottom line is when you took Apixaban plus placebo plus clopidogrel, there's background clopidogrel on all these arms, you had significantly reduced bleeding and similar ischemic outcomes. And then the last one, which Apixaban has not really been into the market much, it will probably come out as years come, but it's basically showing the same thing as all those other trials showed, is that when you combine the DOACs with a P2Y12 receptor antagonist, your bleeding is less. So where did it leave us? I think the statement is very powerful, that in patients with a low risk of thrombotic events or a higher risk of bleeding, early omission of aspirin therapy and treatment with a direct oral anticoagulant plus clopidogrel is completely warranted. So this is back in 2019. So basically getting rid of aspirin and using the novel anticoagulant therapy plus clopidogrel. So if you look over the past 10 years, you can see how we've trended here. We've gone from triple therapy on the left in 2010. We treated all of our patients with this. Just put them on everything you can and see what happens. Well, they all bled. We knew that, but 40% of those patients bled. And you slowly start seeing the top pink part shrinking down. That triple therapy is very rarely used now, all the way up to contemporary date, where we're basically using more dual therapy rather than contemporary or triple therapy. And until prior to this year, we were practicing mostly on consensus guidelines. This was a North American perspective of looking at or telling us that antithrombotic therapy in patients with AF, get rid of the aspirin and use DOACs and a P2Y12 receptor antagonist. And then last December in 2021, the new PCI revascularization guidelines came out. This was a sentinel paper for all of us. It was published actually in January 2022. And first time class 1 indication, meaning robust clinical data supporting in patients with atrial fibrillation who are undergoing PCI and taking oral anticoagulant therapy, it is recommended to discontinue aspirin after 1 to 4 weeks and maintain P2Y12 receptor antagonists, okay? And that is a pretty profound statement. So now these anticoagulant agents are in the guidelines. You can do triple therapy for a 1 month period, but then you can remove the aspirin and keep them on clopidogrel. And so this is actually a nice diagram as we get back to our case. This is the North American perspective as part of the consensus guidelines. You have your default strategy here, and then on the right you have patients that have a high ischemic burden or a high ischemic risk, such as a patient with acute coronary syndrome, and patients that are at low ischemic risk. So our patient's probably going to fall right down here at a high ischemic risk and low to intermediate bleeding risk. So you're going to do a triple therapy. So you'll do a aspirin and clopidogrel plus an anticoagulant for 1 month, and then you'll switch them to double therapy, which will be an anticoagulant with a DOAC and clopidogrel. For patients that have an ACS, you're at least going to want to do 12 months, 1 year. So going back to our patient, just to conclude, we went ahead, and I think you can tell from the guideline, from what we talked about, we went ahead and put a durable polymer DES into that mid-LAD or proximal LAD, and we put her on triple therapy for 1 month with Apixaban, clopidogrel, and aspirin, and then after 1 month, we just continued Apixaban and clopidogrel, and she's been doing well. This was about 3 years ago we did this case, and she continues to do well. So in conclusion, patients with atrial fibrillation frequently have CAD and undergo PCI. And the use of triple therapy with aspirin, P2Y12 receptor antagonist, or vitamin K antagonist together in triple therapy increase the bleeding risk. You want to assign both bleeding and ischemic risk scores. I didn't touch on that, and that's a different talk. But you want to assess your patients for their ischemic risk and their bleeding risk and help tailor that therapy. Now, these patients should come off aspirin even earlier. And the use of a DOAC without aspirin significantly decreases the bleeding risk without concomitant increase in ischemic events. And that's it. Thank you. If any questions, email me. My email is in the brochure.